Probably, yeah. Yeah, it looks like it. Hopefully things will be better after January.
Yeah.
Let's see.
Well, the current leader of our country won't do anything anymore.
Yeah, but hopefully, you may have another one in January. Yeah, it looks like it. Hopefully things will be better after January.
Yeah, I mean, they called the election for Biden.
Let's see.
Well, so the current leader of our country won't do anything anymore.
Yeah, but
you will have,
you
will have a president still alive on January.
After January.
Yeah, I mean, they called the election for Biden.
Let's see.
Well, so the current leader of our country won't do anything anymore.
Greg, why are you saying the same thing again and again now for 3 times?
Because it's very important.
Hi, Zen. How are you? Welcome.
Hi.
They called the election for Biden. I'm gonna sign out and re-sign back in again.
Yeah, I think so. Hi, Amjad. How are you? Same thing again and again now for 3 times.
Because it's very important.
Oh my God, this is. Hi, Zen. How are you? Welcome.
Hi.
What's happening? Imad, can we fix this?
I'm gonna sign out and re-sign
Sir,
back
I
in
think
again.
he's
I
connecting
think
from
so.
2 devices.
Hi,
That's why
Amjad. How are you?
it's coming in.
It's very important.
Oh my God, this is. Hi, Zen. How are you? Welcome. What's happening? Imad, can we fix
Yes,
this?
sir.
Let's all of us mute the microphone and then unmute again.
Yes, I guess.
Better now?
It looks like it's better now.
Okay. I think probably too many people were unmuted. Can you all hear me?
Yes.
Good, that's better. Sandeep is just entered as well. So we are waiting for Joachim. Is he here yet, or is he asleep?
Sir, he's here. He's here.
It's joined already. Joachim's there.
Hey, Joachim, how are you?
Hi. You?
Hi.
Hello. Hey.
Everything
Yeah.
looks good.
Everything looks good.
And Sandeep, why are you still wearing the mask while you're facing the camera? You can unmute yourself, Sandeep.
Because he has to look busy.
Yes, Sandeep, where are you?
Just came.
I think we have a couple of minutes before we start. Nikolai, do you know who's going first?
I think Prof. Chen.
Joachim, correct?
Oh, you're Joachim. Okay. Is it Joachim first?
Yeah.
Okay.
Okay, we still have a couple of minutes to go. So what's the situation in Germany, Joachim? What are you doing with COVID? I'm not talking about Trump. I know you guys vote for Trump over there because you were right next to the big American occupation there in Germany, isn't it?
We have a lot of American patients, so it's very difficult if they cut down the soldiers here. So then, anyway,
So you want Trump to be
COVID,
there?
I don't know. It's there's a lot of warning, but right now we don't have many patients.
Our hospitals are full.
We'll see.
Same here.
What about Paulo? What about in Portugal?
Yeah, it's still the number of patients of COVID patients is increasing, but for the moment the hospital is working normally.
Okay. And Amjad, your place, UK?
He's muted.
He's unmuted
In
now.
UK,
Amjad?
there are more than 20,000 patients per day right now.
Oh my God.
No, I think UK is now steady.
Yes, it's getting steady now.
It's getting steady, and if anything, it's coming down now.
Yeah, true.
But steady at what? What number?
Per day.
Yeah.
Yeah, I think originally they were around 50,000. They were counting every day.
And now they are about 20,000.
know about 20,000.
Yes, but what we see is that the rate of the patients which require hospitalization with oxygen and the deaths are significantly low this time.
Yeah.
Maybe we know a little bit more now about the disease.
That's correct.
We have medications which are working, and so although the number of the patients which are getting the infection and the positive patients are getting are big number, the hospitalizations and the deaths are significantly less than first time.
Yeah, I think the main thing which we found is our university did the RNA testing. The virus is getting weaker and weaker, definitely. And that's why I think the deaths are less. All the number is, the asymptomatic patient number is higher this time than the symptomatic one.
Yeah, that's what's happening in Belfast as well.
Yeah, but I hope that doesn't make people too complacent, because you never know when the virus will mutate and the numbers in tests may go up also.
So just get back to this meeting. Who is going to moderate the session? Is it Nikolai or Pablo, or who is going to do it?
Everybody. You are in trouble. Joachim, you're in trouble.
Chaos.
We all are.
So what is exactly, we have 1 hour, right?
We have 1 hour and a bit. So,
Okay. So
Pablo, would you like to start?
Well, wait. I have on technique and results, like, let me see, 40 slides. So this might be 30 minutes, maybe.
You're good.
That's fine.
And then I have 3 cases, but I think it doesn't make sense to do these cases before Chen. So
Yeah.
I think I just finish with the results and the technique, and then we do the second session. And then if we have time, we can do 3 cases. Well, what is about this?
That's
think
fine.
it's okay?
That's
Yes,
good.
perfect.
That's
Yeah,
good.
perfect.
If we miss the cases, we miss the cases, no problem.
Okay.
Okay.
Let's start.
Okay.
All right. So, Joachim, are you ready?
Yeah.
Right, everybody. I think we have a lot of people logged in already, and it's growing. So it's my great pleasure to present to you Professor Joachim Oertel from Germany. He works in Hamburg Saar, which is close to France, French border. Very good place to live and work. And Joachim is always presenting new and interesting things, so I can't wait. Joachim, please go ahead.
Thank you, Nikolai, for the introduction. Thank you, everybody, for being here and discussing and participating in this meeting. I have the topic vertebrectomy, tips and tricks. And well, yes, I was introduced. So I'm from Hamburg Saar, which is close to the French border. I just have to disclose that I have done several presentations on vertebral body replacement for Ulrich Medical and for Icotech Medical. So one is from Germany and Switzerland, but this webinar today is not supported. But of course, I have some slides and so on where you might recognize the brand, so I want to disclose. This is where I'm from here. So it's the center of Europe, but very small city here at the border to France. Strasbourg is 1 hour, Frankfurt is about 1 hour, and Luxembourg is 1 hour. This is the department, and we do a lot of spine cases. And you might know the Casper system for cervical spine, or the description of the first microdiscectomy by Casper, which was done in this department, well, many years ago. So I want to divide my presentation about vertebrectomy and indication, surgical technique. Then I will focus on cervical indications. And if we have at the end, we have some time, I have brought 3 cases for vertebrectomy we can discuss. So indication, well, indication for vertebrectomy, I think there are 2 main indications. One is the removal of pathological tissue. And well, the thing is, if it's a really solitary tumor, you have to reset everything. So there's a need for complete radiography. This, in our hands at least, this is rather rare. And then frequently second indication is you remove the tissue to gain space to remove, well, most of the tissue, most of the pathological tissue, but to gain space for the vertebral body replacement implant. So just for resection, this is an example. You see, this is a more frequent indication than for 360 degrees approach. So this is a lesion here. When you look at the axial image, you see that the lesion extends to the posterior lamina. So you cannot really remove this part in the cervical only from an anterior approach. You have to come from anterior and posterior. So if you have a solitary lesion like a solitary tumor, you really have to do an en bloc 360 degrees resection. Frequently in the cervical, at least, you have to do an anterior and posterior combined approach. The more frequent indication is the, well, removal of a pathological tissue, decompression of the neurostructures, and then to create a cavity and an ideal recipient site for the vertebral body implant. So what are the frequent indications? Well, infections is a very frequent indication for us. We have a lot of spondylodiscitis. So like here on the left side here, you see a typical spondylodiscitis and of the L3-4 disc. And it's very difficult to, you can discuss what are you, when you want to do surgery for discitis, but if you have a lot of loss of bony tissue, we don't hesitate to put in a vertebral body replacement. So this is, I think, a very good indication for a vertebrectomy and vertebral body replacement. Here in the middle column, typical tumor situation. If you have a solid tumor, which involves basically only one vertebral body, this is an ideal indication for vertebrectomy. And then, of course, you have trauma like this in an osteoporotic case here. You cannot really restore anything without removal of the remnant of the vertebral body and put in a vertebral body implant. Also, a very frequent indication in the cervical is degenerative. Like in this case here, you see this looks in the multi-level spinal stenosis, but when you look at this level, and you look at the CAT scan, the corresponding CAT scan at this level, you see that everything is calcified and this is not a soft disc. So if you really want to remove the space occupying lesion, I think you have to extend the approach and do a anterior cervical spondylectomy. Deformity and destruction. Well, this is a rather rare indication, particularly if you had earlier surgery, more challenging. I did not bring any example. Surgical technique. Well, basically, you can come from straight anterior, straight posterior, and from lateral. And I don't want to go too much into details because this will just take too much time. In the cervical, we, except for C1 and C2, we come from a standard anterior ACDF approach. And this is possible down to T1, sometimes even T2. Very difficult is the approach to T1 to T3, to T3 with splitting of the sternum, and then difficult also is T4 to T12 and the lumbar spine. Posterior approach and the cervical for a radical vertebrectomy, I think you cannot come from posterior only, you have to do an anterior approach. And the thoracic area, well, if you sacrifice the nerve roots, then it's possible to come in many indications only from posterior. And in the lumbar, well, lumbar is very challenging, at least in our hands. I remember only one really vertebrectomy purely done from posterior with preservation of nerve roots. This is very difficult to preserve the nerve roots if you have to do complete vertebrectomy. So now I want to switch to the cervical indications. Cervical spine has some peculiar characteristics. It's a high range of movement, a low axial load, high disc space, and the particular configuration of the facet joints. So we have frequently a lot of degeneration, and it's a very frequent indication for surgery, cervical spine disease. We have two basic approaches from anterior and from posterior. And for the vertebrectomy, for the complete vertebrectomy, only the anterior approach is a good option. The difference is mainly in the exposure of the spinal canal and the central nervous system structures. And if you have to really expose everything from the nerve root, from medial to lateral, from this spinal cord, the posterior approach might be added to an anterior vertebrectomy anterior approach to have a 360 degrees exposure and stabilization. So what are the indications for an anterior cervical corpectomy and fusion? Well, it's in our hands mainly degenerative. We have a lot of degenerative indications, particularly OPLL, and then trauma, tumor, metastasis, infections, and deformity surgery. So basically the same as we have in the thoracic and lumbar situation. For the corpectomy and for the graft and stability, we have various options. There's autologous iliac crest and fibular autograft, allograft, mesh cage, expandable titanium cage, and the carbon peak cage, which is recently brought to the market. Actually, the iliac crest autologous graft, we don't use very frequently anymore. It's a very high fusion rate, but there's a significant donor side morbidity. And the allograft is another option. We have basically no experience with the allograft, but it's widely used, in particularly I think in the States, as far as I'm informed. We have no donor side morbidity. It's very high fusion rate, but we have a problem with infection and graft resorption, and it's a limited availability. Mesh cage, it's a frequently used cage. No donor side morbidity, also very high fusion rate, but in our hands, it's rather difficult to implant. So the most frequent vertebral body replacement we use is an expandable cylindrical titanium cage. We have no donor side morbidity, adjustable size and length, no excessive end plate preparation. The fusion rate is unclear. Subsidence rate of expandable cages remains unclear. So this is an example here. This is here how you can expand the cage with a fixation screw here. Then you have to add an anterior plate. Another example is this one. This is the cage with an integrated anterior plating. So, well, I personally don't like this one that much. I prefer the separated cage and anterior plate, but this is another option for this combined technique. A recent vertebral body replacement for the cervical spine is an carbon peak implant, and we have used this now for the 6 cases. I think this is a very nice indication if we have very poor bone quality. We need post-operative good imaging. So with this carbon peak implant, you have basically a normal MRI with very, very small artifacts. And actually what our radiation therapists told us, they prefer these implants because they have a better dose calculation than with the titanium implants in tumor cases. But the disadvantage of this implant so far is that it needs a very meticulous preparation of the end planes. It's rather difficult to implant in comparison with the expandable cages. So what about the technique? Well, when you do a literature review with a cervical vertebral body replacement, you see that there's a lot of complications reported, like in this 2006-2008 subsidence rate up to 36 to 42%, and then reoperation rate up to 20%. Just a couple of examples how we use the anterior vertebral body replacement. This is an example here. You see, you might think this 3, 4, 4, 5, 5, 6. It's a cervical myelopathy patient. You see that there's a spinal stenosis at these 3 levels. But when you do the corresponding CAT scan here, then you see that everything here is calcified. So it's basically posterior ligament calcification. So I think if you want to really decompress all these structures, then you have no option than to do an anterior cervical corpectomy. And this is our setup. I hope that the video runs without any problems. This is Dr. Burkhardt, one of our spine consultants. See that we almost always use a right-sided approach. There are reasons why you have to come from the left, but in general, if you're right-handed and you have the option to come from both sides, then actually we prefer the right-sided approach. And this is important. We use the Casper retractor and bring in the Casper screws in the adjacent vertebral bodies that you can distract the whole area, the whole distance. Then we start with a discectomy. And in my opinion, this is very important to start with a discectomy because you want to prepare the end plates perfectly and you want to decompress the nerve roots, I think, which is much easier if you start with these in the beginning. So this is now discectomy. You saw this is a vertebrectomy C4 and C5. So we do a discectomy 4, 5, and now we do 3, 4. In this case, it's rather no calcified anterior ligament, so it's easy to do this. So then we do the discectomy, and then after the discectomy, we do the oncoforaminectomy, which is not shown in this video. But I think it's very important if you have to decompress the nerve roots, then do this in the beginning. It's much easier than in the later on. So as soon as we have decompressed the nerve roots, we drill 2 cuts, one on the left lateral and one on the right lateral. And then we use a diamond burr or regular burr to make these 2 cuts and do the corpectomy. Then the last step is to decompress the spinal canal. So the calcified ligament, mostly calcified ligament in these cases, in these degenerative cases, is removed. And then hemostasis is obtained. If it's a tumor or you have to go more lateral, then this is the next step. After hemostasis, you go lateral and you expose either the lateral, well, vertebral artery, whatever you want, or resect all the tumor, lateral, contralateral, and ipsilateral. So this is now the 2-level corpectomy. And this is now the implant, how we select the implant. You need a test implant. And this is quite difficult to get an ideal implant. You see, in this case, it was very difficult. Either the one is too short or the other one is too long. And then the implant is brought in. And when you see that the test implant fits perfectly, then you switch to the final implant and bring this in. This is a very convenient vertebral body replacement system because you can adjust the angulation of the end plate and expand the cylindrical cage. This is done under a little bit destruction, and then as soon as you have the vertebral body replacement, the implant in the optimum position, as you have seen now, you relieve the destruction, and then it has to be in a good position, in a stable position. In tumor cases, this is more difficult because you cannot destruct. If you have a poor bone quality, you cannot destruct as well. So then you have to pay more attention. But here in a degenerative case, I think it's very convenient because you can do this on a little bit destruction and then bring this in an optimum position. Lateral and AP X-ray is very important to have an ideal position of the implant. And as soon as the vertebral body implant is in ideal place, the plating is very easy. This is an example of a plate. It's a Mambo plate, which is, I think, at least in Germany, it's no longer on the market. But I like this plate very much because it gave a very stable anterior osteocentesis. And then for the plating, the preparation of the anterior surface of the vertebral body is very important. So I love the diamond burr to vaporize the bone and to make a real plane, clean plane, and then you do the testing with the plate. And as soon as you have an optimum position, only if you have an optimum position of the plate, then the plate is brought in and fixed with screws. If you don't have an optimum position of the test implant, don't proceed with the final implant because it will get even more difficult. Puncture of the screw is, I think, important. Some are self-tapping, some are not, but I love to give it a little bit direction with a diamond burr. And then the fixation screw in the center is fixed. So this is a 2-level corpectomy. Pretty standard case we do in the degenerative spine. And now you see the AP and the lateral X-ray. And I think this is very important that you have ideal position of the implants in the AP and lateral X-ray. Another example, and this is with the carbon fiber peak cage vertebral body replacement. You see here, this is a case with the hyper intensity signal on the T2 image at C4 and 5/6. And this patient came for decompression, and we decided, because patient had a severe symptoms, we decided to do anterior corpectomy C5. And with the C5, since frequently you have deterioration later on, I think this is quite a good indication for a carbon implant that you can do an MRI without artifacts later on. And you see here the orientation. This is cranial, this is caudal, this is lateral, left and right of the patient. And this is the anterior end plate, the anterior border. This is the end plate of the C4 base. And this is the C6 cranial end plate. And the vertebral body is already removed. And this is an example for the carbon peak implant. You have to prepare the end plates very well. And it's a good indication because it's not a degenerative indication. This is a not expandable cage right now. So this is pretty much like putting in a mesh implant. So if it does not perfectly fit, you cannot adjust it. You can adjust the angulation of the end plates. So it's a multimodal system, but it's not possible to further expand the cage. So here, I think it's important to use a distraction device and then put in the cage. 60 degrees on one side and the other side 0 degrees implant. The disadvantage with this carbon peak implant is that during the procedure, it's rather difficult to get the ideal position of the implant. So this is the carbon peak implant, because there are only small markings. You don't see the implant in the X-ray very well. And this is then combined with also another carbon peak anterior plate, which is also a little bit stiff. So you have to prepare everything in the optimum position with the diamond burr, the anterior plating. This is the test implant. Look whether this fits well, and then the anterior plate is brought in. Same technique as with the standard titanium plate, drilling, and then putting in the screws. This is the post-op MRI as an example, that you see almost no artifacts. You can really nicely see even the anterior part, the CSF anterior to the spinal cord, that everything is decompressed. And this is one of the big advantages with this implant. Here, this is the same implant in the CAT scan. You see that you can, in the CAT scan, quite well see the structure of the implant and the position of the implant. X-ray is very difficult. You only have small markings. you need some experience that you know that the implant is going to fit well if you start with this technique. So tips and tricks. I'm almost through with the first part of my presentation. So we always use, or almost always use, right-sided approach. Wide exposures is important. So frequently we have a very small exposure for vertebral body replacement, and then you cannot bring in the implant. You never know whether the position is good. So wide exposure is important, and definition of the midline. And this definition of the midline, at least in our hands, we frequently use the Casper screws to put them ideally right in the midline, because then you have the midline marked throughout all the procedure. Sufficient retraction of the muscles, and then application of retractors is important. And if possible, the insertion of the Casper screws in the adjacent vertebral body gives you good intraoperative orientation and destruction. For the vertebrectomy, we always start with a discectomy. Cleaning of the implants, don't sacrifice the implants. This is the graft recipient side, the implant recipient side, and you need optimum position there. And then the next step after discectomy is the decompression of the nerve roots. And then after oncoforaminectomy, the corpectomy follows. I personally like the 2 cuts on the lateral and then do the vertebral body removal. And the last step is to remove the calcified ligament. And if it's needed, like in tumors, resection of the lateral vertebral body is then done to expose the vertebral artery and the lateral border of the vertebral body. For the implant, preparation of the implants is important. You need a sufficient hemostasis. So if we use fibrin glue, putty, or even Tacoseal if there's any problem. And I think the important thing is that the test implant has to be under minimum destruction in an optimum position. If you don't have an optimum position of the test implant, don't proceed with the final implant. The final implant will never fit better than the test implant. If the test implant don't fit, don't proceed. Before preparation of this surgery, I always check if we have lateral and AP position X-ray, so that you have during the procedure the possibility of optimum X-ray control. And when you put in the final implant after removal of the relief of the destruction, we test the stability, and then we remove the Casper screws later on. And then anterior plating follows. Anterior plating, I think the important thing is that you have to have the vertebral body replacement in the optimum position. Then you can use the vertebral body position, replacement position of for orientation for the anterior end plate. And for the anterior end plate, we have to prepare the anterior plane of the adjacent vertebral bodies. If the vertebral body replacement has the optimum position, it's good for guidance. And then insertion of the screws, a little bit aiming medial and a little bit aiming cranial or caudal for the cranial screws, caudal for the caudal screws to get an optimum stability. I have brought 5-year results of 135 anterior cervical vertebral body replacements from our department. You see that it's mainly degenerative, couple of tumor cases, couple of infectious cases, couple of trauma. 60 were done with this expandable cylindrical cage. 75 were done with this expandable cylindrical cage with integrated anterior plate. And the immediate postoperative outcome was about 75% success rate with improvement of pain, sensory deficits, and motor deficits. And the 6 months follow-up did not change much. It was a higher number than of no motor deficits, but overall success rate was between 75 and 80% with respect to symptom subsidence. There was a revision rate of about 10% with either implant. And you see here, these are the causes for the repeat procedure. Mainly subsidence and plate dislocation. So it's mainly if you have a poor bone quality or not an suboptimal implant position, then you have to expect they have a high risk of repeat procedure, screw losing, subsidence, breakage of caudal screw in one case, and so on. So basically a problem with the implant position and dislocation. So in our hands, I think anterior cervical corpectomy is a very useful option. Frequently, you have to do the anterior cervical corpectomy in many indications. But there's a significant complication revision rate, about 10 to 15%, depending whatever you count for a complication. If it's transient for a couple of weeks, I would not count it a severe complication, but it's up to 15% that you have some aspects you have to consider. So the indication for corpectomy has to be made carefully before and considering all the complication and revision rates. Well, I think I hand over now to Chen for the next, and then we can discuss and have 3 cases. Is that okay with you, Nikolai?
Yeah, either way. So yeah, we can discuss and have questions later, and or we can. Yeah, I think probably that's best. Let's do that way. So probably now we can continue with Professor Chen, and we have all the discussions at the end. Salman, what do you think?
Agree. Joachim, you just need to unshare your screen so that Zen can share, please.
Is that right? Did I do it right?
Yeah, you're all right. Then please go ahead and share your screen.
Okay, I'll share my screens. Where is it?
Okay, right. While that's happening, pleasure having with us Professor Chen from China, who has very interesting presentation, and he has very good experience with treating of cervical chordoma and with 3D printed prosthesis. Interested to see all that again.
Hi, good evening, our colleagues, because it's evening in Beijing. And I'm Dr. Chen from Beijing Chen Hospital, and my topic is the treatment of cervical spine tumors with 3D printed processes. And this is our hospital, Chen Hospital. It's also we in China International Neuroscience Institute. Our spine section just on the 4th floor. And every year we have about 2,000 cases out of spine and spinal cord cases. For primary spine tumors, usually en bloc are recommended. But how to reconstruct the spine column is still some problems. In the beginning, sometimes we use iliac bone crust to reconstruct the anterior column of the spine. For this case, C7 to T1 meningioma, and we remove the vertebral body and reconstruct with iliac crust. But 5 years later, the tumor recurrent and destroyed the auto bone graft. So it's with a bone graft, with autonomous bone graft, it's not very suitable for this kind of primary spine tumors. But of course, we use a mesh to reconstruct the anterior column of spine. But with mesh, there is a very high rate of subsidence, and this will cause the loss of the normal curve of the spine, and sometimes leading to the failure of the internal fixations. In recent several years, we have some new technique. It's called the 3D printed technique. With this technique, we can have a more suitable solution for the reconstruction of the spine columns. It was first used by our Spain colleagues. They use 3 printed processes to reconstruct multiple levels of spine. For this, they reported with the 3D printed processes, they reconstruct 5 levels of thoracic spine, thoracic lumbar spine, and remove the tumor en bloc. After remove the tumor en bloc, and also with this kind of processes, it's very suitable in some special areas such as upper cervical spine and also sacral spine, because in this area the anterior column is very suitable. It's very difficult to reconstruct with mesh. If we contrast with mesh for the upper cervical spine, it's not always stable. For example, in this case, we can see the mesh turned to one side and it's not so stable. But with 3 printed processes, we can reconstruct the upper cervical spine more stable. And this is reported in 2012 by Chinese orthopedic surgeons. And in this year, our orthopedic doctors reported this case, tumor infected the whole cervical spine, about 7 levels. It's chordoma, and they remove the whole of the multiple level cervical spine and reconstruct with a huge 3 printed processes. Also, the 3 printed processes is very suitable in sacral region, because if the tumor affected the S1 and S2, at that area, the tumor will destroy the first joint between of the sacral and iliac joint. So we should reconstruct the stability between this joint, and the 3 printed process is very useful for this kind of reconstruction. We can see with this kind of technique, it's in the literature, they reconstructed the joint very perfect. And from 2 years ago, we use this kind of 3D printed processes to reconstruct the spine column for the spine tumors. This is a 11-year male, a boy. He suffered T4 hemangioma, and with we reconstructed from posterior and from posterior approach and remove whole the vertebral body and reconstructed with 3D printed processes. And this is another case. He suffered C6 to C7 chordoma. We can see he's a 15 years old boy. We use 2 approach. First, we use a posterior approach to remove the posterior structures of the cervical spine. This is the video of our first stage operation. Because the membrane of the tumor is very thin and tiny, so it's hard to keep it intact. We try to separate around the membrane, around the border of the tumor, and remove the whole tumor from posterior. And we remove the first joint and the transverse process of C6 and C7. And then with the posterior approach, we reconstructed the posterior structures of the C6 and C7. Then in the second stage, we use the anterior approach to remove C6 and C7 vertebral body. First, we we perform SDF in the C6, in the C4, C6, and also in the lower level. After the upper and the lower disc is removed, and then we perform the vertebral body resection. We cut open from the left side and remove the two vertebral body totally. With this method, we can decrease the recurrent rate of this kind of tumor. And after that, we this is a whole C6 and C7 vertebral body we removed. And then we use 3D printed processes to reconstruct the anterior column of the cervical spine. And this is a CT scan after operation. And the MRI showed the tumor was removed totally. So this kind of technique is very useful in upper cervical spine reconstruction. We meet a lot some cases of upper cervical primary tumors. Usually, this kind of tumor should be performed surgery in two approaches. First, posterior approach, we separate the posterior structures of the cervical spine and separate the vertebral artery. And the second approach from anterior transorally to remove the residue of the vertebral body. And totally, we have 10 cases in 2 years of the upper cervical primary tumors. 8 of them is chordoma. 1 is aneurysmal bone cyst. Another one is hemangial perisitoma. And with anterior approach, we choose in 9 cases we choose a transoral approach, and another case we choose a high retropharyngeal approach. And the most cases was receive radiotherapy. And this is a case of hemangial perisitoma. He's a male, 38 years old. We can see the tumor destroyed the C2 vertebral body. So we can see it compressed the dura. And before operation, we designed the 3D printed processes. And then in the operation, first with the posterior approach, we remove the posterior structures of the C2. And then transorally, we remove the residue of the vertebral body and plant the 3D printed processes. And this is another case. He suffered C2 chordoma. He's a male, 56 years old. With the posterior and anterior approach, we removed the whole C2 vertebral body and reconstructed with the 3D printed processes. Another case suffered C2 chordoma, a huge chordoma, and with this is how we design the 3D printed processes. In this case, I also designed the lateral mass of C2, and then we can make the reconstruction more stable. And also we can have some design of the screw, how to plant the screws. And in the operation, first we perform posterior approach and remove the structures and plant the screws and also the 3D printed lateral mass of C2. And then in the second stage, transorally, we remove the whole C2 vertebral body and implant the 3D printed processes and fixed with screws. This is after operation. This is another case. Here's a little boy, 12 years old. He suffered C2 aneurysmal bone cyst. Though it's not a malignant tumor, but the tumor destroyed the vertebral body, and so we should remove the tumor and reconstruct the balance of upper cervical spine. First, in the first stage, with the posterior approach, we can remove the posterior structures and plant pedicle screws in C1 and C3. And then after the first operation, with the posterior approach, we adjust the balance of between C1 and C3. With the CT scan after operation, after the first operation, we design the C2 processes. And then in the second operation, we transorally remove the residue of the tumor and implant the 3D printed processes. This is 1 year after operation. We can see there's no residue of the tumor, and the process is have some confusion with C1 and C3. This is the most difficult case I met. He's a recurrent chordoma and involved C2 to C4. This patient have performed 4 surgeries 4 times. And with the CT scan, I designed the 3D printed processes. We would like to reconstruct from C2 to C4. In the first stage, we perform posterior approach and remove the tumor from posterior approach. It's important to separate the vertebral body from the tumor and protect it. And also the nerve root. Then in the second stage, with high retropharyngeal approach, I remove the anterior vertebral body from C2 to C4. This is the upper face joint of C2. When the face joint are removed, we can see the vertebral artery V3 segment, and I protected with some cotton, and then we can see the tumor are removed totally. And then I implanted the 3D printed processes and reconstructed the whole upper cervical spine. This is 1.5 year after operation. The patient recovered very well. So to summarize my lecture, I would like to say that 3D printed process have some advantage in the reconstruction of the vertebral body, vertebral anterior column, and the subsidence rate is very nice, and the bone graft is not needed, and the processes can be personalized, designed for upper and lower cervical segments. Short-term follow-up result is satisfied. Thank you.
Thank you, Professor Chen. It was really interesting, and it's very, very good solutions for problems that we sometimes have to do difficult decisions. So I really enjoyed the lecture. So now I think that probably we can proceed further with some questions and maybe some case presentations after the discussions. Are we okay with that?
Yes.
Right, so I have a question for Joachim. He mentioned when he presented that he does not like the expandable cages with the integrated screws. Joachim, would you please explain why you don't like these cages?
I don't like might not be the correct term. You know, it's not my decision what I like and what I don't like. The thing is, the angulation of the vertebral body replacement and the plate, integrated plate, you really have to prepare a very well the recipient side, and it does not fit perfect, and then it's easier to have a separate vertebral body replacement implant and a separate plate. I think in the beginning I used this very much, but now if you really want to have a perfect alignment of the end to the end plates of the vertebral body replacement, I think it's easier to have it separate. But the results, as you have seen, the results are similar. So, you know, based on the results, there's no difference.
Have you seen biomechanical studies to elaborate on which one is better biomechanically? Is it separate?
No, I have only seen clinical studies with 60 to 78 cases. This is what I represented. In our cases, we have the same subsidence rate and the same revision rate, 10%, no difference.
Okay, thank you.
Joachim,
yes.
Maybe just asking you about some points that I would say that I tend to do differently from what you do, and I'd like to have your comments on that. First is that I tend to do much more multi-level discectomies than carpectomies, because typically you can just drill up and down if you distract the end plate. So most of the osteophytes, I think you can remove if they are not too high or too low behind the vertebral body. Second is that I tend when I have a preserved low doses and osteophytes anteriorly, I tend to go posteriorly because the spinal cord goes back, and I think it's easier to, and you can decompress well posteriorly comparing to anteriorly. And last thing about the expandable cages or the expandable vertebral body substitutes, the reason I don't like them very much is because you have much less space to put your graft in for degenerative cases. I use them for tumors, but not that much for spondylosis. Can you comment on these three issues, please?
Yeah, the first is maybe the most important is, of course, we have many more multi-level discectomies. I mean, it's maybe if you do multi-level discectomies, maybe 10% of the cases you do corpectomy, very few. So the standard for degenerative is multi-level discectomy. And then you rather, remove little part of the posterior part of the end plate and ossifies, and this is sufficient for decompression. Also, I have to say, if I think that I add posterior decompression for various reasons, that you have a really, anterior and posterior spinal canal stenosis, severe symptoms, then we rarely do corpectomy in these cases, because when you add posterior decompression, then it's no problem. The second thing is posterior. Well, actually, I don't agree. I completely don't agree with the. Well, I know that there are two schools. One do everything from posterior, others do everything from anterior. So the recovery is much faster from anterior with all the patients. The posterior approach causes a lot of problems with pain. At least in our hands, we always have only problems with the posterior approach, never with the anterior approach. They have some swelling problems, some swelling for 2-3 days, and then they're done. You can send them home, they don't come back. With the posterior, they really complain about neck pain for weeks, months. So if I have a chance to come from anterior or posterior, I always come from anterior. There's no doubt. If I have to come from posterior, of course I do posterior. Posterior approach is easy, it's fast, it's not a problem. So if I have the option, anterior or posterior, I'd rather come from anterior. So what was the third one? The third thing?
The expandable, the space for the graft.
The bone, yeah. Well, yes. Well, what we do with I did not show you the images. What we do with the corpectomy, we actually, if it's degenerative, we use all the bone and put it aside around the cylindrical cage. With this, it's okay, but if you want to put it inside the cage, there's basically no space. You cannot put any bone in there. I agree. So if you want to use a lot of bone, like in a traditional idea to obtain fusion, you have to use another implant. But actually, we have now more than, I think, about a little bit more than 200 of these cases, and we will bring this up, I think, in the next year. We will publish the results, the subsidence rate and the graft complication rate after the first 4 weeks is basically zero. So we don't have any problem with implant failure or screw loosening. It's very few. Only in the beginning. The beginning, yes, 10%, but then it's not a matter of really not obtaining fusion. So it's very, pseudarthrosis is extremely rare. But I mean, I just don't like we do a lot of posterior. I mean, but maybe it's because of the tradition here, because Kaspar used to work here, he never used posterior. We do a lot of anterior approaches and we're happy with it.
Greg, do you want to comment on this?
I don't have any exposure to the expandable cages. I don't like them because people tend to over distract them, is what I see. I think you have to be very careful when you use them. I use a stackable PEEK graft for all my corpectomies. It's something you can just measure the size and you can just put together on the back table and put it in. It has great space for bone graft. And that's been the problem with a lot of the grafts that are around, is that you really should seek to get bony fusion, whether you put it around or you put it in the middle. I think it's better in the middle, in the center of the graft, and will hold things considerably better. I've used this PEEK graft now for probably 10 years. It's been available here, and it works great. The markers in it are certainly good enough that you can see it on a post-operative X-ray. I think the difficulty with the titanium cages is you can't really see if you're fusing. It sounds like Joachim doesn't need to do that, but I think for most applications that I think that's reasonable. I do have one question about the 3D printed grafts for Zen, and that is what material is it made of? And what's the titanium? But what's the infection rate? I mean, you do a lot of these through the transoral route, and I'm always one that says that
Yeah, there is one question like that from the chat as well. Infection rate in transoral application.
Yeah, and I know that with titanium, you're have a lower infection rate. Because it doesn't hold on to bacteria like stainless steel does. And so I was just wondering if there's long-term follow-up on the infection rate. And then a lot of these are chordomas, and even though it's titanium, it has to have some effect on postoperative imaging. And do they use proton beam therapy afterwards?
You mean after operation infection?
Yes.
No. Yeah, in our patient, we have almost no infection cases. Because they did some special technique for transoral approach, and because we have to do a lot of CVJ malformation, and some cases we should do anterior approach. So in our center, we do a lot of transoral approach, and the infection rate is very low.
Well, I have a question. I mean, I thought it's PMMA actually. So this is titanium implant. So that means you cannot do anything with it. It has to be perfectly, it has to fit perfectly. This is interesting because, I mean, we use titanium implants in the craniotomy cases, for craniotomy cases when we have the titanium implant custom made and put it in. And actually, we don't use it anymore because even if it's custom made, it does not fit perfectly in many cases. So then we went back to the PMMA custom made cranioplastic cases technique. So this is interesting. I think this is, I think that might be very challenging to have a titanium implant because you cannot do anything with it, right? It has to be really, it has to perfectly fit the recipient side. How do you achieve this? How do you, how do you do
Very good
this?
question. Very good question. For the lower cervical spine or thoracic or lumbar cervical spine, it does not need a personalized printed. We have 2 millimeter different. We can choose one to print to implant. Okay, but so for upper cervical spine, we should personalize 3D printed. We should use the CT of the patient and design personalizedly. And usually, I just have the same worry of you of the point. So I design 3 different sizes. Every size 2 millimeter longer, 2 different sizes. So when we perform posterior approach, first the cervical curve are a little changed before different with the CT scan before operation. So we have to in the beginning we finish the operation at the same time. In the morning posterior approach and in the afternoon anterior approach. But later I found that after posterior approach, the cervical spine, the curve are changed a little. So the 3D printed process are not so perfect. Later, we separate the operations into 2 stages. After the posterior approach operation, and then we check a CT scan again for the patient. And with this CT scan, I design the 3D processes. And 7 days later, after the 3D printers was made, we do the second operation.
And may I make a question also to Professor Chen? Is that I have no experience on going transorally and extending my exposure laterally. So it's the classical indication for transoral is that your pathology is within the central, like 20 millimeters or so. So it's for midline pathology. So when you drill laterally and you cut, you drill in the lateral mass of C2. So you have the vertebral and the arteries underneath. It gives, for me, it looks like really challenging to do that.
Yeah, it's challenging. For we use a posterior approach to solve this problem. With the posterior approach, I remove the lateral side of the first joint and separate the vertebrae with 3 segments and push it laterally. And then anterior approach, we just need to remove the central part of the vertebral body. And it's very much easier to remove it and implant the process.
Okay, thank you.
Paolo, there are some questions. If you could read those questions out to Professor Chen regarding, so there's a question about the best age group. I don't know what it means.
There was also a question about the price.
Professor Chen,
price.
yeah?
In China, the price is about $5,000 US dollars. One level process.
Okay, brilliant. Nikolai, shall we move towards the cases then?
I think, yeah, probably we, because of timing issues, we have to probably start with the cases. So I think Joachim had a few cases to present.
I have a case, yeah. Let's see.
You want to go ahead?
A moment, wait. I have to do this now. Okay. You see my screen?
Yes.
Yes.
It's working. So it's well, 62-year-old male patient, known thyroid cancer. And this is his MRI. So he has to undergo thyroidectomy and some lesion here in the pharyngeal muscles, but this is also a lesion here. It's a non-continuous lesion, so it's in the C4 vertebral body. And the CAT scan, it looks like this. So it's most likely metastasis, but you see here that it's not related to the thyroid. Well, at least it's rather metastasis. It's not grown continuously from the thyroid to the lesion site. Patient had indication for thyroid surgery. So what would you do with a C4 lesion? Actually, I have to give you the information that the oncologists, they said that this is so far a solitary disease, non-metastatic disease. So they wanted to, were highly interested in obtaining histology on this C4 lesion, because it had some influence on the treatment protocol. Actually, I don't remember the treatment protocol very well anymore. So what are the options with this C4 lesion?
Can you go back? Yeah, can you please go back onto the imaging?
Yeah, I come to the imaging. So stability, compression of neural structures, need for histological diagnosis. I think stability is not impaired here. We need histology. And what about, he has no symptoms. Here. This is the lesion. I just have the sagittal and the CAT scan with the axial here.
So there's Yusuf says C4 corpectomy in cage. Would anybody embolize this?
Yeah, because I was going to ask, yeah, this is probably going to bleed.
Embolize?
Yep.
Really? Interesting. My experience with embolization is very poor. I think it doesn't help. Interesting.
I think you need to change your radiologist, man. Your intervention.
No, they're good. They're extremely good.
Maybe this is not so big lesion, so maybe you can go ahead with that.
I don't have I have no scale with it, but this might be, what is it, 1 by 1 centimeter?
Yeah,
very
that's
small.
right. Yeah, it's not so big lesion.
Yeah, I mean, this is, let's pretend here, this is maximum 20 millimeters, so it's 10 by 10 or 8 by 8 or something.
Yeah.
So what were our ideas? We thought it's probably stable. There's no instability. I mean, the bony structures around the lesion looks good. Well, mild compression of spinal cord. You see this here. It's a little bit mild. It's just pushing it posterior, but no symptoms. Well, there was a need for histology important for further treatment. So I think this is an ideal case for anterior corpectomy. I mean, if you're there, you will not just obtain the diagnosis and go back. I think then you go in and replace the vertebral body. So this is what we have done. And you see again, this is a separate plate and destructible cage. I think this is an ideal indication because we will not put any bone graft in there since this is most likely metastatic disease. And then you just put in the destructible cage and the plate. Carbon vertebral body implant would also be a possibility, but here, since it's not a disseminated disease so far, it's the bony quality is good and it's not that important to get an idea of the adjacent structures.
Did you go posteriorly as well?
Actually, yes. They went actually, I didn't, this is not the case I did, but we also added posterior C3 to C5.
What was the indication for that? It's
Well,
just single level corpectomy.
The thing is, yeah, usually what we do, we add a lot of posterior as soon as it's 2 or 3 level. 3 level always, 2 level we discuss, 1 level we usually do not. But here, I don't remember. Probably it's the bony quality, the impression was that it was not as good, and then we're not reluctant to add posterior. Posterior is 30 minutes, and we discuss it with the patient, and if we add posterior, actually the risk of screw loosening and implant failure is almost zero.
Yeah, and you have some, in fact, you have some sinking of the cage in the vertebral and the lower vertebral body. So eventually that could have been seen during surgery. And the other thing is that when you go posterior, you can add a fusion if you want. So
yeah. Here in the tumor case. But particularly if you want to have a sufficient decompression, and I mean, you think it's just in most of the case just lateral mass, they add a lot of stability, the posterior approach. It gives a very stable 360 degrees fusion.
It's just more pain, as you just said.
This is the reason why I don't like the posterior. Otherwise, it's very straightforward. You get the results immediately. You decompress everything. Anatomy is nice. The only thing is they all complain about pain. I mean, maybe it's the sensitive Germans.
Yeah. I would say Portuguese people don't complain about pain after posterior laminectomy. They complain about pain when you do laminectomy and fusion, yes, because you detach more the bone. But when we do like 15 to 20% of our degenerative cases from posteriorly, either with laminectomy or laminoplasty. But typically there are patients who are almost fused anteriorly. So they have a lot of osteophytes. So they are old patients with the low doses. And we don't, well, they have some pain, of course, but it's not the main issue in my hands.
There is very good paper published in 17 from Ed Benzel and co-workers about the comparison anterior versus posterior. So a large group of patients examined. So they concluded that if you can go anterior because faster recovery, faster going back to work, less complications.
Well, I don't know about the long term, but we have done the long from the posterior. We have done the long term for the anterior, and the success rate, meaning that the patient will undergo the same procedure even after 20 years again, is close to 100%. It's unbelievable. All the patients which have not had a significant complication, they all go for another anterior procedure when they suffer the same. So there are a lot of papers from us. We followed all these Kaspar patients, the first patients from him, and they basically the the satisfaction rate is extremely high. It's unbelievable high. In the beginning, I did not believe it. I thought it's faked, but it's true.
Okay, shall we do the second case? I think we have time for one more case quickly.
One more case. Okay, let me see. Okay, I just do the second one. I think the third one might be better, but it's okay. 60-year-old male, severe gait ataxia, severe paresthesia of both hands. And this is his image. Well, this is probably, maybe it's not nice low doses. I don't know what Paulo's going to do, but you know, since we like from anterior, we will.
I would go for anterior here.
Actually, let's see. So what are the options? This is the CAT scan. It's not that much calcified, but you see here there are a lot of osteophytes here. So this is another case you could discuss that you do this. Let me see. I think I have it in the image. Well, is there an issue for stability? Probably not. Compression of neural structures, nerve roots, yes. Paresthesia in the hand, so you want to decompress not only spinal cord, but also the nerve roots. Well, there's no need for histology. So these are the options. Conservative, surgery, anterior posterior C3 to C6, anterior C3 4 5 3 4 5 6 or 3 4 4 5 5 6. What would you do? Well, actually, I just put this case together. This is from presentation. I would, when I do it now, I probably would do a 2-level corpectomy and a posterior, add a posterior fusion. But well, it's not one of the options here. So what is your idea, Nikolai? What would you do?
Sorry, Joachim. Carlos Villa is saying laminotomies.
Yeah, posterior.
Okay.
In China, we have lots of these kind of cases, much severe OPLL. And in China, we have a new technique, anterior spinal canal enlargement. And later, I can present a case of this kind of patient.
Yeah.
For this case, I will do.
So anterior. What is your point? Anterior.
Anterior, yes.
Anterior. Yeah, but the question is anterior multi-level decompression instead of doing a corpectomy. That's what I would do.
I would go for a 3-level ACDF drilling of the osteophytes and plating.
I probably will be tempted to do the same, but the lower level looks like there is a big bulge there behind.
This is challenging. I mean, this is bone.
Yeah. So this anterior might be. I would be concerned that I might do insufficient decompression there. So I probably will go corpectomy, as Joachim said.
Okay, possibility. I think, but nowadays it's possible, as we said.
Yeah.
So this is what I think. Posterior, you have not the compression side, so it's an indirect decompression. You give the spinal cord space to move posterior. Well, in multimorbid patients maybe, but since I said we prefer anterior, so it's possible. But when you see here, you have to angle it a lot, and then if you start to do the drilling, then you have to sacrifice the end plates if you want really to do the decompression. So.
Yeah.
This would be another case. Probably Paulo would not do this corpectomy, but I think we would do corpectomy in this case.
What is the age of the patient?
60 years.
Okay.
Yeah, my point is what you put in you put in your drawing. So you destroy the end plates, of course, but basically the posterior part of the end plate. So your cage will be docked mostly anteriorly. Then you have a plate. So. Yeah.
Well, but only the thing is here. Yeah. This is, I think, maybe 3 millimeters. This is maybe 4. So posteriorly only if you really distract the segment.
Yeah.
If it's already fused, then you have to sacrifice the end plate all the way because you cannot bring in any instrument.
Yeah, but it doesn't look like fused. That's what I was saying. So
Okay.
the disc height is not that bad. So if it was fused, he wouldn't need surgery.
I don't agree. I mean, this is, it might be fused now, but you know, he just needs a minor, as we have saw this heard this very nice presentation by Dr. Reda in the personal column online meeting. If we have minor trauma, he might be a central cord syndrome, you know, and then I think he needs decompression. Well, anyway, so what we did is, I will accelerate a little bit. We did a 2-level compactomy, actually. Same technique. I will not go too much into details. Let me hurry this up and then put in the implant.
Did you go posterior as well on top of this?
I guess so. We will see in the next second. Yes. Yes.
Okay, very good. So
we just skipped the third.
yeah, I think
Is that right?
Professor Chen
Okay.
to present the case.
Then let's skip the third. Thank you. Thank you.
Salman, do we have time for another case? Professor Chen,
I think if we can do it in a few minutes, yes. Can we do it in a few minutes?
Dr. Chen?
Yeah.
On my case.
Can you just quickly show this, please? We just have a few minutes to go.
Okay, okay. Very special case. Yeah. It's a female patient. He suffered paralyzed 10 days ago. Before admitted to hospital, upper muscle strength decreased, lower muscle muscle strength decreased, and this is a CT scan. So the OPL multi-ligament multi-levels, and this is a CT scan. This is a CT scan. K line is negative, and the lordosis is lost. And axial view, we can see the lesions and the lesions, multi-lesions from C2 to T1. And the MRI showed the spinal canal stenosis. And how to perform this kind of operation? Who have ideas?
Yeah, I think as you suggested, there are now there are lots of case series coming out from various parts of the world on this anterior movement of the vertebra to create space, or you can do the posterior. So both would work equally the same, whatever is safe in your hand.
Because usually K line is negative, posterior approach will be much less effective. And this is an axial view of MRI. The axial view of MRI showed severe compression. And we have another new technique, ECF. And this is called, we can enlarge the spinal canal from anterior. And this
how
is
difficult is it to do so? I have seen this kind of presentations from you and other colleagues from your country, and I'm always worried about drilling in the lateral part of the vertebral body and pushing it towards the plate.
Of course, it's dangerous as part of operation, but we have do more than last year. We do more than 10 cases. All of them are recovered very well. For this patient, we do the operation from C2 to T1 with ECF, but we need a more longer plate. But we have our plate just shorter than what we need. So between the level of C2 to C3, the decompression is not enough. So with this level, we do the posterior approach, posterior decompression later. And this is after operation. After operation, you can see we drill laterally. And the patient strength, lower extremities recovered to 3 levels just 2 days after operation. We can see the MRI showed the decompression. And later we performed posterior decompression at the level of C2 and C3. And because what we need a more longer plate, we can reserve this patient. And after posterior approach, we decompressed the spinal cord totally. I think with this technique, we can change the strategy of how to treat the spinal canal stenosis. Thank you.
Okay, good. I think that's an option, and as you said, there are lots of studies coming out now with this. Having said that, the numbers are very small, and at the moment they're showing minimum morbidity, but I think we have to be skeptical in the long run what's going to happen. We just need to wait for the results, but the results are reasonable. Imad, have you got something to show us for what do we have for after a fortnight? Imad, you there?
Right. So next webinar in 2 weeks will be we will be presenting. It will be so Michael Fellings from Canada will be presenting on cervical myelopathy. I don't know if Imad has a poster to present, if he's there.
He has, but I think he's somehow disconnected or something. I don't know. I don't see him here. It's okay, no problem. But as long as this is exactly in the same time after a fortnight.
Yes.
So everybody most welcome. I'm sorry, won't be able to see the poster since we can't look at Imad at the moment. Any comments from Joachim, Zen?
No comments. I think no comment. Excellent, excellent. Everything good. Thank you.
Okay, so we have the poster now for the next webinar, which is on 22nd of November. We will have Michael Fellings presenting on degenerative cervical myelopathy. Another interesting and eternal topic, and so looking forward to it. Okay.
Paolo, you can close.
So thank you for joining again, and we look forward to having you on our future webinars. If you have any topic or any presenter that you would like to see here, please let us know, and we will be mostly welcome to incorporate them or to include in
and also for the juniors, if you have an interesting case that you would like to present and you would like to discuss with us, and to hear different options from the participants, also welcome to submit to us.
Okay, can we have the group photograph? Just a group photograph. Can everybody switch on their videos, please? Switch on your videos, please. Thank you. And you can smile. It's okay.
Yes, remove the masks.
Okay, a video, please. Can you switch on your videos, please? Thank you. Everybody. Imad is done?
Yes, sir.
Okay, thank you. Nicola, you want to wrap it up, please?
Yeah, so another interesting session that we had today with interesting presentations and cases, and it's getting only more and more interesting with the presenters that we have. I'm looking forward to the next one, which is in 2 weeks. with Michael Fellings.
Okay, thank you, everybody. Bye-bye.
Thank you. Bye-bye.
Bye.
Bye.